Welcome to this explainer on diabetic retinopathy. Look, we all know that living with diabetes is a daily balancing act, right? But today, we're zooming in on one of its most profound and, frankly, most feared complications. We're going to bridge the gap between some really complex medical science and the very real everyday reality for millions of patients across the globe. We're going to break down exactly how this disease physically impacts the eye, and much more importantly, how we can actually stop it. To really master this topic, here is our roadmap for today. We'll cover the global threat, dive into the pathophysiology, explore the clinical spectrum, and then wrap up with diagnosis and medical management. All right, let's jump right into part one, the global diabetic threat. To understand the scale of what we're dealing with, just look at this number. According to the 2021 IDF Atlas, there are a staggering 537 million adults living with diabetes globally. I mean, that is an enormous slice of the world's population managing this chronic condition day in and day out. And here is where the direct risk to vision becomes absolutely undeniable. Out of all those diabetic patients, fully 1/3 are going to develop diabetic retinopathy. The duration of the disease is actually the strongest predictor here. Within 20 years of diagnosis, up to 60% of type 1 and 40% of type 2 patients will start seeing these retinal changes. The urgency of this, it literally cannot be overstated. Diabetic retinopathy isn't just a minor issue. It is the #1 leading cause of working age blindness in adults aged 20 to 74 years. So we aren't just talking about a medical problem anymore. This is a massive socioeconomic issue that strikes people right in the prime of their lives and their careers. But wait, before we get too gloomy, here is the absolute game changer. Vision loss from diabetic retinopathy is 95% preventable. 95%. That's incredibly hopeful, isn't it? It means that with timely screening and the right treatment, we can almost entirely eliminate blindness caused by this disease. So how exactly does this happen? That brings us to section 2, how blood sugar actually harms the retina. Think of this as a microscopic chain reaction of destruction. It all kicks off with chronic hyperglycemia. Long-term high blood sugar activates these really destructive metabolic pathways. Specifically, we're talking about the polyol, AG, and PKC pathways. What these do is alter how cells process energy and handle stress. This kicks off intense oxidative stress and mitochondrial dysfunction, which literally damages the delicate cells lining your blood vessels. This microvascular damage thickens the basement membrane, it causes the capillaries to just block up completely, and it breaks down the blood-retinal barrier. So essentially, all that high sugar is starving the retina of oxygen, causing ischemia. And in a state of sheer panic, the oxygen-starved eye sends out an SOS, a distress signal protein called VEGF. To get really precise for a second, the absolute earliest microscopic histologic hallmark of this disease is something called parasite loss. That's the loss of the crucial little cells that wrap around and stabilize your capillaries. And that distress signal I just mentioned, that's VEGF-A. It's the central mediator that tricks the eye into rapidly growing, fragile, leaky new blood vessels in a desperate, totally pathological attempt to get more oxygen. This right here is our primary therapeutic target. Now let's move to section 3 and see what this actually looks like in the clinic, the stages of retinal damage, from NPDR to PDR. Understanding this clinical spectrum is super critical. It kicks off with mild NPDR, where we mostly just see microaneurysms. Moving into moderate NPDR, things escalate. We start spotting hard exudates, which are these fatty protein deposits, along with cut and wool spots and venous beading. Then we hit a really dangerous tipping point, known as severe NPDR. In the clinic, we define this using the famous 4-2-1 rule. Basically, if a patient has severe hemorrhages in 4 quadrants of the eye, venous beading in 2 quadrants, or intraretinal microvascular abnormalities, those are abnormal branching vessels we call IRMA, in just 1 quadrant, they are at a super high risk of tipping straight over into PDR. PDR stands for proliferative disease, and that's the endgame, where we see that dangerous neovascularization, bleeding right into the vitreous gel, and even tractional retinal detachment. So all those abstract terms we just used, they translate into a devastating physical reality. Just take a look at the severe, visible damage on a real human retina. You can see the scattered hemorrhages, the widespread structural breakdown, and those exudates littered across the tissue. It's a very real, very severe clinical picture when it gets to this stage. But hey, I need to throw in a massive caveat here that we absolutely must address. While retinopathy generally walks step by step through those stages we just covered, Diabetic macular edema, or DME, plays by its own rules. DME is swelling in the macula, which is the most sensitive central part of your retina. It is actually the leading cause of vision loss in these patients. And the most crucial takeaway? DME can strike and steal vision at absolutely any stage of the disease journey, whether it's mild or severe. All right, moving on to section 4, diagnosis and screening. Let's talk about how we catch this before it's too late. Your very first line of defense is actually a pretty accessible, everyday bedside tool, the fundoscope. Through a simple dilated eye exam, direct and indirect fundoscopy allows clinicians to physically look right into the back of the eye. It's how they spot those early warning signs, like the microaneurysms and exudates. It's standard, it's totally vital, and it really forms the bedrock of early detection. But, sometimes we need to look deeper, and that's when we turn to two high-tech diagnostic marvels. First up is OCT, or optical coherence tomography. Think of this like a non-invasive optical ultrasound. It gives doctors micron-level precision to measure the exact thickness of the retinal layers and hunt down that dangerous macular edema we were just talking about. Then we have fluorescein angiography. For this, we inject a glowing fluorescent dye into the patient's veins to completely map out the retinal blood vessels. It pinpoints exactly where those tiny capillaries are blocked off, or where brand new abnormal vessels are actively leaking fluid. Because catching this early is literally the difference between sight and blindness, the screening timelines are incredibly strict. For type 1 diabetes, screening begins 5 years after diagnosis, and then you do it annually. But for type 2 diabetes, screening must begin at the exact time of diagnosis, and then annually after that. Why the difference? Well, because type 2 diabetes often goes completely unnoticed for years. That means serious retinal damage might have already started by the time the patient even figures out they have high blood sugar. Now, there are a few critical exceptions to those rules. Pregnancy, for instance, carries a major risk for a really rapid progression of retinopathy. Because of that, screening is required pre-conception and then again during every single trimester. For patients who already have established retinopathy, they need closer monitoring, usually every 3 to 6 months. And honestly, what's truly exciting right now is that AI-based retinal screening and teleophthalmology are rapidly expanding access to these vital exams. This is a huge deal, especially in resource-limited settings where an eye specialist might not be just down the street. Okay, bringing it all home with Section 5, medical management, specifically systemic risk factor control. I like to call this the holy trinity of DR prevention. Number 1, glycemic control. You've got to keep that HbA1c below 7%. The landmark DCT trials showed a massive 76% risk reduction just with intensive blood sugar control. Number 2, blood pressure. The target here is below 130/80 millimeters of mercury. And preferably you want to use ACE inhibitors or ARBs because they've been shown to reduce disease progression entirely independent of just lowering the pressure itself. And finally, number 3, lipid optimization. This means utilizing statins for all diabetic patients and adding in fenofibrate. Huge studies like Field and Accord Eye have proven that fenofibrate can reduce DR progression by another 30%. Managing these 3 systemic factors, it massively protects the eyes. So we've covered a lot today. The staggering global numbers, the microscopic chain of damage, and the amazing tools we have to fight back. But at the end of the day, all this dense medical science really comes down to one deeply personal, very actionable question. When was the last time you or a loved one with diabetes had a dilated eye exam? Remember what we said earlier? 95% of this blindness is completely preventable. But that's only true if you act in time. Don't wait for your vision to change.